country. My first introduction to Nigeria was through Lagos, the capital. It's here that the medical headquarters are situated, and here that I met the Director of Medical Services before the beginning of my first tour. The DMS, Dr. Manua, explained the system of decentralization from his headquarters through the regional offices to the districts. In the districts, the ultimate responsibility for the hospital and rural health work rests with the district medical officer, an assignment of considerable variety and interest. Dr. Langdon, as a single man, was going to take over a field unit in the northern territories. He would be completely mobile and would cover vast distances in the treatment and reduction of epidemics, mass surveys, and research work. My job was to be in the south, as medical officer centered on Calabar in the Creeks district, an area of approximately 4,800 square miles. Next day, Dr. Langdon set off on his 600-mile trek north by train. I went by air with my wife and small son, who had come out with me. Calabar is the name both of a town and a medical area. The focal point of my work is the General Hospital, St. Margaret's. There are also 5 smaller ancillary hospitals, including units for maternity cases and infectious diseases, and 7 outpatient dispensaries scattered throughout the area. The work, of course, is far more varied than one would expect to find in a European country. In addition to the clinical conditions common to all countries, the range of tropical diseases is very extensive. One of the great advantages that the Colonial Medical Service has over the system at home is that a medical officer can follow his patients right through. He acts as physician, surgeon, and social worker, and the patients remain under his own eye until the treatment has become effective. Besides a very large outpatient department, this hospital has 140 beds with a nursing staff of 36 orderlies and 10 nurses who work under the supervision of a European state-registered nurse who acts as matron. To assist me at the hospital, I have 2 African doctors, one of whom acts as house surgeon. There are 2 operating theaters at St. Margaret's, both well equipped with instruments for general use. There's no anesthetic apparatus, so spinal, pentothal, or open drop methods are used. Hernias of all kinds form the majority of cases on a theater list. The surgical conditions common at home, such as appendicitis and so on, are rare in this part of Africa. The old tales about West Africa being the white man's grave have long since been exploded. We find the climate of Calabar somewhat trying in the wet season, but on the whole, all 3 of us keep remarkably fit. Our house is airy, pleasant, and well equipped. And we're supplied with homes, by the way, and at a fixed rent. There is plenty of domestic help, and this alone makes housekeeping much easier for my wife than at home. As for my son, Jonathan, he has different pets, but that's about all. When he's old enough, we shall have to send him back to England for his schooling. Still, that won't be for some time. A doctor's life is the same wherever you are, and you can't get away from the job for very long. It was a call from the sanitary inspector to say that there was a suspected outbreak of cerebrospinal meningitis at a village called Big Kwa. This is normally a job for the medical officer of health, but as he was already up country, I was asked to call in and pick him up en route. I found the medical officer of health at St. Andrew's College, carrying out one of his routine checkups. He's responsible for public health. He has 10 qualified African sanitary inspectors to assist him in this work, which is much the same as that of an MOH at home. Fortunately, the center of the reported outbreak was accessible by car, and not, as frequently happens, miles out in the bush. As soon as we arrived at Big Kwa, we met the chief of the village and learnt from him the extent of the outbreak. The district commissioner had already arrived to give what assistance he could. The conditions in Nigeria are still similar to that of Europe 100 years ago, when community-wide diseases took their toll of the population. A great number of these people have already been rendered anemic by hookworm and malaria. Their resistance is therefore so low that an outbreak soon reaches epidemic proportions. These epidemics usually occur in the dry season, about Christmas time, the infection being dust-borne. Through the district commissioner, we commandeered a suitable building for use as an emergency hospital, and also made arrangements for the sick to be brought in straight away from the surrounding area. At the same time, we sent a telegram to regional headquarters at Enugu, asking for the help of the nearest mobile field unit. These units do a great amount of research work out in the bush, and consequently it sometimes takes a day or two for them to get back to their trucks and so to the scene of an outbreak. Meanwhile,